Greetings, everybody. We're going to talk here about carotid artery disease. So, carotid artery disease is simply atherosclerosis of the carotid arteries. So, it's the same thing as coronary artery disease, except this is happening in the carotid arteries instead of the coronary arteries. The risk factors are just the risk factors for atherosclerosis. So, diabetes mellitus, hyperlipidemia, particularly an LDL to HDL ratio of greater than 3 to 1. Smoking, and then some of the non-modifiable risk factors such as male sex, advanced age, and genetic predisposition. All of those work into a patient's susceptibility to atherosclerosis and therefore for carotid artery disease, to develop plaques in the carotid arteries. Carotid artery disease is the most common underlying cause of stroke. So when you look at your causes of stroke, about 85 to 90% are thrombosis, which means a blockage, and about 10 to 15% are hemorrhage, which means a spill of blood from the arteries. So in this case, when we're talking about cerebrovascular disease, carotid artery disease, we're talking about thrombosis. We're talking about mostly here embolization, which would be either a thrombus from the heart, or carotid artery debris, which can be sent up to the higher arteries, or primary vascular occlusion, which would just be a atherosclerosis that's built to the point of 100% occlusion. And then I just want to point out here, embolization is also the cause of TIA and amaurosis fugax in addition to stroke. All right, so the manifestations of carotid artery disease, as I mentioned, are transient ischemic attack, and this is a mini stroke. So what that is simply stroke symptoms that come on quickly, and usually they last for about 15 minutes or less, but they can last up to a day. So this is what's referred to as a mini stroke because the symptoms are transient. Amaurosis fugax is a form of TIA in which you've got an emboli that's sent to the retinal arteries, and it causes transient monocular blindness, so blindness in one eye, which ultimately also goes away. And then the big one is cerebrovascular accident, which is the big stroke, and this causes long-term symptoms, longer than a day. So these are all the manifestations of carotid artery disease. And of course, you can also have carotid artery disease as just an asymptomatic patient. Long-term medical management includes modifying risk factors. So the risk factors, diabetes mellitus, of course you'd want to have that under control. Hyperlipidemia, statins are useful, and then stop smoking. And then if that's not enough, then antiplatelet drugs or anticoagulation can be useful as well. The surgical management for carotid artery disease, which is going to be the focus of this talk, is carotid endarterectomy. Now there are surgeons who are using carotid stenting now, and that's fine, but I don't suspect that that's going to come up on the USMLE. Carotid endarterectomy is the traditional gold standard surgical treatment for carotid artery disease. And it's the one that you'll be asked about on the test. So, as I mentioned, here's the causes of stroke. We're primarily here concerned about embolization, particularly embolization of carotid artery debris. So you develop a plaque on the carotid artery, and from that, then you can get debris, smaller pieces from that plaque, embolizing off and causing a blockage in a smaller artery. So this is your carotid circulation. You're kind of looking here from the right, kind of at an angled look here. So your arch of your aorta would be down here. You can't see it. So you have your innominate artery on the right, which comes off the arch of your aorta. It gives off the subclavian artery, which ultimately goes to the arm, and then also gives off your right common carotid, which will then give off the external and internal carotid arteries. On the left, your carotid artery, common carotid artery, comes directly off of the arch of the aorta, and there's a separate branch off the arch of the aorta for the subclavian. And then the internal carotid artery is what ultimately is going to communicate with the circle of Willis. So this is all communicating circulation. So the manifestations of carotid artery disease, kind of referred to this a little bit earlier. Probably the most common would be asymptomatic. Most patients who are older have a certain degree of carotid artery plaque. Whether you'd be able to hear it on physical examination as a bruit or not depends on how severe it is, but most patients with carotid artery disease are asymptomatic. Now, the ones who have symptoms, they usually have to have either a TIA, the amaurosis fugax, or have had a stroke. So it's difficult to see patients who just come into the clinic with this. This is usually a patient that's going to come into the ED. So the transient ischemic attack, as mentioned, is like a mini stroke. It's an acute focal neurologic symptoms. So basically, the way to think about this is just a stroke, but it has a rapid onset and a quick resolution. And usually it resolves within 15 minutes, but it can, by definition, go up to 24 hours. And what this is ischemia of the brain tissue. So the brain tissue is not working properly. And that's kind of like if the brain tissue were dead, where it's not working at all. So you're having stroke-like symptoms, but it reverses. The capabilities come back. The neurologic symptoms go away. Now, I want to contrast that with the cerebrovascular accident, CVA, or stroke. That is where the symptoms have lasted longer than 24 hours by definition. This is necrosis of the brain tissue, and in most cases, there are going to be irreversible symptoms. Now, when we're working up a TIA or a stroke, it's going to be a little different than when we're just working up plain old carotid artery disease, and I'll refer to that in a little bit. And then amaurosis fugax is kind of, like I mentioned, a specific type of TIA where you get this transient blindness in one eye, and that's caused from an embolism to the retinal artery. Now, there's a lot of different things that can cause amaurosis fugax, not just embolism. So some of the things that can also cause it would be, in addition to an embolism from the carotid artery, you can have an embolism from the directly from the heart, from the left ventricle. You can have giant cell arteritis. Lupus can cause it, as well as some of the vasculitides like polyarteritis nodosa, eosinophilic vasculitis, and I think, as I mentioned, lupus can cause it as well. So there's lots of things that can cause this. It's not just emboli, but this is a manifestation of carotid artery disease that's worth knowing. And on ophthalmologic exam, it may be brought up that you can note in the retinal artery, you can see a plaque on the ophthalmologic exam. I don't expect that you'd ever be able to see this with your ophthalmoscope. This would be more of the formal ophthalmologic exam with a better piece of equipment that a ophthalmologist would do. But again, another thing worth noting, because the test likes to bring up these words. Okay, so the history of patients with carotid artery disease, as I mentioned, usually this is a pretty dramatic presentation. So the patient with carotid artery disease often has a previous or possible previous stroke, TIA, or amaurosis fugax. Also in their history, they're going to usually have risk factors for atherosclerosis, so they're older, there's a tendency towards males, maybe they're smokers, they've got diabetes, those things. Symptoms, there's very few symptomatic manifestations besides the neurologic symptoms themselves. On physical exam, really, really important to associate with carotid artery disease, the carotid artery bruit. And why do you have a bruit? Because you are going through a narrower space. So you have your carotid artery, which is getting narrowed by the plaque, and now you're going through a narrower space, and it's causing that turbulence, which causes a bruit. And it's just like the turbulence that you would get if, say, you had aortic stenosis. You got a smaller space, and so now you're going to have more turbulence, and it makes a louder noise. So the carotid artery bruit is usually going to be heard right around the angle of the jaw, right around where you can palpate the pulse of the carotid artery, and that's right about where the common carotid artery splits into internal and external carotid. And that's just because that's the most common place for people to get plaques developing in their carotid artery. It can be confused with a transmitted heart murmur. So the best way to differentiate the two is that the carotid artery bruit would get quieter as you move down the neck, and also a heart murmur, you should be able to hear it on both sides, whereas the carotid artery bruit, you'll probably only hear it on one side or the other, or more on one side than the other. So a carotid artery bruit is much more asymmetric in appearance, if you will. The carotid artery bruit is an alert, not just for carotid artery disease, but for other atherosclerotic disease. Carotid artery bruit are actually more associated with heart attack than with stroke, and that's just because it takes a lot less atherosclerosis to get a heart attack than it does to get a stroke. So certainly any patient who has a carotid artery bruit should be worked up for all kinds of manifestations of atherosclerotic disease. So certainly an EKG would be something you'd want to get on these patients. A carotid artery auscultation is an important part of a physical exam, just a normal physical exam for any older patient or patient with risk factors for carotid artery disease. So for diagnosis, if a patient has an asymptomatic bruit, the best initial diagnostic test is going to be a duplex ultrasound of the carotid artery. And that's just what it sounds like. It's an ultrasound of the carotid artery, and you're able to see what direction the blood is flowing, and from there, then you can see if where the plaque is and how much occlusion you've got. An EKG is also good to get on these patients, just because you're also working them up for other atherosclerotic disease. So you want to see if maybe they've had any silent MI. But the best initial diagnostic test with a patient with an asymptomatic carotid bruit is going to be a duplex ultrasound of the carotid artery. Now, how about the symptomatic patients? Well, symptomatic patients with carotid bruits, those are patients with TIA and stroke. And a patient with a stroke, you're not going to be worrying about what's going on in their carotid arteries because they've got a much bigger fish to fry. You're concerned about their stroke. So with those patients, usually you're going to do a CT to work up their stroke. And so I talk about this management of stroke in the neurology section. So you can go back to that. I'm not going to talk about that here. So this is a duplex ultrasound. You've got your transducer here, and it just sends silent sound waves to the carotid artery like any ultrasound. So here's a normal duplex ultrasound, and they're not quite in the exact same spot. These aren't the same devices here, but here would be a good example of a normal finding. So red is just is movement away, and blue is movement towards. I'm not an ultrasonographer, but you can. What this just means is that all the blood is moving in one singular direction. Now, what you see here on the abnormal ultrasound is that you've got blood moving in one direction, but then right here you've got a part that is you don't have blood moving properly, and so this is actually the plaque right here. And don't worry, you do not have to read these for the USMLE. I just want you to get a visual idea of what you're doing with a duplex ultrasound. Don't worry about having to read these. You won't have to read these for the USMLE, ever. Okay, so when do we intervene surgically? When do we do surgery for patients with blockage in their carotid artery instead of medical treatment? Well, there are two studies that are sort of our landmark studies for doing carotid endarterectomies, which is our treatment of choice for patients with carotid artery disease. And those studies are NASCET and ACAS. Now, NASCET is focused towards patients who are symptomatic, and by symptomatic, we just mean symptoms within the last 6 months. So let's say you have a patient who had a TIA, had a stroke. You've treated them from their stroke, discharged them. Now we need to take a look at their carotids and see what we can do to prevent another stroke from happening. These are still symptomatic patients if the stroke happened within the last 6 months or the TIA happened within the last 6 months. So that's what that means. It doesn't mean acutely symptomatic. I mean, it can, but these are symptoms within the last 6 months. Defines what a symptomatic patient is. So for symptomatic patients, according to this study, a carotid endarterectomy should be performed in patients with 70% or greater blockage. Now, in asymptomatic patients, so this would be like your typical man or woman, 65 years old, comes in for their routine physical, and you hear a carotid bruit. These patients, when you do their ultrasound, if you see 60% or greater blockage, then you should do a carotid endarterectomy. It is indicated. Now, there are contraindications to carotid endarterectomy. Usually these are pertaining to the very sick patients, so not so much the asymptomatic patients. And the contraindications are going to be disabling stroke with an acute loss of consciousness, mostly with this just referring to acute strokes. We're not going to be doing carotid endarterectomies with acute strokes. We're concerned more about the blockage. Patients who have 100% or more occlusion, we don't do carotid endarterectomies for those patients. And then patients with a severe medical illness, which results in a shorter life expectancy, we'll probably not do endarterectomies for them either. And really, most of this is just at the call of the surgeon and the anesthesiologist. The last of which is probably the anesthesiologist. The severe medical illness, shorter life expectancy, that just puts them at a higher risk of dying on the table. So definitely, though, remember these two facts. 70% or greater for symptomatic, 60% or greater for asymptomatic. Now, what is the carotid endarterectomy? It's a surgical procedure. You're removing an atherosclerotic plaque from the carotid arteries. Now, when you do this, the patients are going to be monitored on EEG because you want to know what's happening with their brain function. And the anesthesiologist or a trained professional who reads EEGs will be looking at the EEG and making sure that nothing wrong is happening. Because when you are doing this procedure, you are clamping the arteries, so you do have a relative decrease in perfusion. So what you're doing with this procedure is you clamp your common carotid, your internal carotid, and external carotid, and then you have your area to work with where you can then make an incision into the artery. And once you make the incision into the artery, you can remove the plaque and then stitch the artery back up and then take the clamps off. Sometimes surgeons like to have like a conduit so that they're still shunting blood over back up to their brain, and that's just on that's the call of the surgeon. You don't need to worry about whether or not you have to do that for the USMLE. What you do need to know about the carotid endarterectomy for the USMLE is that the patient needs to be monitored on EEG, that the patient may be awake or they may be put under general anesthesia. That depends, but either or. And then the complications, of course, include stroke and ischemia. You can get injury to the hypoglossal nerve or the vagus nerve, and that's because they run so close to the carotid artery. Hypotension is possible, and that's because at the bifurcation of the carotid artery, you have your carotid sinus, and that's a very sensitive space for detecting blood pressure. So you can, if you monkey up with that, you can get hypotension. So you have to be careful in looking at the patient's blood pressure while you're operating on them. And then rarely hyperperfusion syndrome can happen, and that would just be because you're getting sudden increase in flow of blood where you've had decreased flow of blood for so long. And then, of course, general surgical complications, which I talk about in previous sections. So this is just to give you an idea of what this surgery looks like. So here's this is the patient's ear, you can see here, and so this is like the sternocleidomastoid area, and so here's the common carotid artery, which is splitting into internal and external, and the plaque is probably right around here, so this is where you're going to do your incision and pull out the plaque. But the clamps will be placed here, here, and here, and the hypoglossal nerve is right here. And that's CN12. So what you're doing is you're just making the incision, pulling out the plaque. Pretty simple procedure. I made a brief reference to carotid artery stenting earlier. This is being done more and more commonly. It's a good intervention. You've probably seen it done, or you've heard of it done, and it certainly could be done in most patients. But for the test, carotid endarterectomy is still the one that they're going to ask you about. It's the gold standard for surgical treatment of carotid artery disease. So you won't be asked to choose between the two. Carotid endarterectomy is the most studied, and so this is the one that's going to come up on the test. So just to recap, carotid artery auscultation should be done proactively as part of any general physical examination in middle-aged and older patients. I would say probably at least after age 50, and also in patients who have significant risk factors, so early heart attacks in the family, early strokes in the family, familial hypercholesterolemia for sure, patients with long-standing uncontrolled diabetes, patients who have been smoking for a long time, etc. Carotid bruit is an indication for a full workup for atherosclerotic disease. So the best initial step is going to be a duplex ultrasound of the carotid artery because we want to look at that first. But after that, then these patients should probably come in for an EKG. They should probably do a stress test because you're looking to see if there's anything else that may have happened, considering we know that they've got atherosclerotic disease. So just kind of looking at it broad picture. Now, the indications for carotid endarterectomy, and if there's nothing else that you take from this lecture, please at least take this. The indications for carotid endarterectomy are at least 70% blockage in symptomatic patients and at least 60% blockage in asymptomatic patients. Medical treatment, such as antiplatelets and blood thinners, can be undertaken in other patients. Now, you may be wondering, why is it a higher blockage for threshold in symptomatic patients and a lower blockage threshold in asymptomatic patients? I have no idea, but that's what the studies say. So if anybody knows why that is, please feel free. Any surgery residents, please feel free to explain that. I don't know why, just remember those numbers. So contraindications are disabling stroke, 100% occlusion, or severe comorbidities. And then complications for this particular surgery include stroke, ischemia, injury to local nerves, and blood pressure instability. And with that, that should be it for carotid artery disease.